Top Med Talk.
So what we're trying to do is the plenary session, but also speaking to people who are going to listen to this online as a podcast. There's an organisation which many of you will know, some may not, called Evidence-Based Perioperative Medicine. We've run meetings in London and Ireland and the US for about 25 years. And we've partnered up with this meeting for several years. So we exchange speakers and we co-promote the meetings. And Evidence-Based Perioperative Medicine now has essentially a broadcasting arm called Top Med Talk. So we are doing a live Top Med Talk interview. I'm Mike Grocott. I'm a professor of anaesthesia from the UK, but I'm one of the co-editors-in-chief of Top Med Talk. And I'd like to introduce my co-host, Kate Leslie.
Hi, I'm Kate Leslie from Melbourne. I'm a specialist anaesthetist and I'm a new co-deputy associate editor-in-chief of Top Med Talk, Down Under.
So we are going to be introducing Denny, Levett and Gerrit Slooter. So I'm going to ask you to introduce yourself, Denny, first.
Hi, my name's Denny Levett. I am an anaesthetist and perioperative physician and an intensivist from Southampton in the UK. And I chair, along with Gerrit, the International Prehab Society.
My name is Gerrit Slooter. I'm a surgeon from Holland. We're going to be talking about prehabilitation. We got introduced to that many years ago, being a humble surgeon among anesthesiologists. It's my task to spread the word.
We're honoured to have a humble surgeon with us. So if we could just start off, we're going to do a little bit of introductory discussion of the organisation and the meeting and where it's come from and where you might be going to, and then talk through some of the topics that maybe pick up themes from the week. So can you tell me where the International Prehab Society came from?
Yes, so we established in England back in 2007 something called the Perioperative Exercise Testing and Training Society, which was based on the premise of trying to promote education, good practice and research in the field of perioperative exercise testing. A natural evolution from the education in perioperative exercise testing as the literature developed was the advent of exercise training and prehabilitation. We started to focus on both the testing element but also the prescription of exercise. And as the prehab literature grew and developed and we learned about the other pillars of prehab, we started focusing more on prehabilitation. And meanwhile, Gerrit.
One of my PhD candidates met the godfather of prehabilitation, Professor Carley in Montreal. We went there with an international group to talk about prehabilitation and the initiative of doing a large randomized trial. We were lucky to have a sponsor from the Dutch Cancer Society to host the trial. We created an international consortium with our friends, front runners in prehabilitation. We needed to meet, so we decided to start an international conference in Eindhoven, the Netherlands. It was a success. We decided at the end of the conference to initiate the International Prehabilitation Society with our first honorary member, Professor Carley. We created a board and started out. Then a few times later, we thought about bringing things together.
Yeah, absolutely. It seemed our objectives were aligned and it seemed not a great idea to have two parallel societies. We hosted the second IPS meeting in London in 2019, just prior to COVID. Then we all paused for a couple of years whilst COVID happened.
But sorry, I have to interrupt. Your meeting in London was brilliant at the British Museum, completely sold out. I was so proud being there amongst Egyptians and British together.
It's unusual for two organisations to manage to merge. In the United Kingdom, we have an association of anaesthetists and a college of anaesthetists, and there are parallels in the physicians and surgeons communities, and they happily, they exist in parallel. How did you get over that hump of bringing two organisations together?
We were individuals trying to promote prehabilitation, reach out to the world. You need a staff, you need management, you need people to do the secretary work and help you be a professional organization. And since Denny and our organization were quite far ahead, we decided to join and make use of the bureau to spread the word.
Absolutely. And I think there were a number of the same suspects on the boards of the two organisations, so that made things somewhat easier. And it seemed to combine resources and expertise was a better idea. And what we certainly feel for the future is that we'd like to have the organisation as a resource for individuals implementing prehab around the world, with educational resources and chapters in different countries where people are able to learn from each other.
That's correct, because whenever we go to meetings like this, you get your pink-colored glasses on again. Everyone is pro, and it seems like you're fighting the fight together.
As a first-time attendee at this meeting, the word family is often used to describe the community of practitioners and researchers. How did that family come together? Was it through the conferences or your research program?
Actually, the family started way back in Montreal. I'm a surgeon, and I used to go to surgical conferences in the world. They're all surgeons, usually wearing suits. But then this is truly a multidisciplinary thing. So you need physical therapists, you need nutritionists, you need anesthesiologists, and so on. So you're more in a family-shaped environment. That's why we call it a family.
Yeah. I think Franco Carli, who we all saw earlier on, was a great leader from that perspective, because he has always worked with a very multidisciplinary team. Before we established the societies and had official meetings, he invited us all over to Montreal a couple of times in a more casual format. He was always very open to having visiting juniors come and learn about prehab. He established a feeling of collaboration right from the beginning, which has been helpful in pushing the research forward. Certainly for your study, those were some of the people that entered into the prehab studies international sites.
So the consortium is a family as well. Bringing people together during dinners and in bars with beers makes you a family as well.
Where's your next meeting?
I know,
Ooh.
but I'm not going to tell you.
It's probably more than 8,000 kilometers from here.
There are a lot of places that are 8,000 kilometres from Melbourne.
Almost everywhere is 8,000 kilometers.
That leads us on to our next topic, international comparisons. It seems like different countries or regions of the world are in different stages of their development in prehab. Can you reflect on how the competition's going? Gerrit, do you want to talk to us about that?
There are weird things going on in the world. If you're in Australia or in the UK or in Canada, those countries are front runners, I think. It's usually anesthesiologists that are running the program. Whereas if you're in Holland or in Germany, it's the surgeons that are eager to do this for the patients. And so that makes it a completely different work. They think we're arrogant, and we need them. It has to be a joint effort all around the world, and that's a lot of difference. I discussed this morning, the resources over the various countries are different.
What about the United States? That hasn't been mentioned so far.
It's true that it's hard to get. We have a lot of very supportive listeners in the United States.
It's hard to get the United States involved. I don't know why. They might have a completely different system. I think that they have a shorter reach to Canada, but I don't know.
We were talking about this earlier on another podcast, that the American system is highly privatized and it's a federation of 50 states. So there's a great deal of opportunity for new things to arise, but also a lot of difficulty in coordinating care in a situation like that.
From our experience, some of the people we've spoken to from the States, the clinicians are excited by and interested in the concept, but they had struggled to date to find a way to introduce something new in the way that they are funded in the private system. So they needed to find a mechanism of billing the insurance companies, which seemed to be very important for to be able to implement it within the health system, which, again, I just think really reflects the fact that the organisation of your health system impacts how you might go about getting funding centrally for prehab and recurrent funding. And it also will impact what sort of prehab system or type of service you need to implement. So in a very rural area, it's going to be different than in a city, different challenges.
Do you think some of that reflects the cultural elements? We've already talked about Franco's leadership, and he set a brilliant culture in the family. But if you look at the healthcare culture, say Holland, I always think of as a country where prevention is very prominent.
I guess you're right. I first have to compliment you on your diplomatic answer why the US isn't involved. And it's true. We have prevention, meaning tertiary prevention, seems to work. We want our patients that encounter the hospital that being fit and being healthy is part of the strategy to get through whatever treatment they need. So that's correct prevention.
Am I right? You have a Ministry of Health and Sport? Or
It is a combined ministry, but it switches once in a while and they separate again and come together again, depending on the area, middle or right wing. And
I can't imagine anything like that, for example, in the United States. And it is notable. It's the integrated systems with more of a focus on prevention that have really embraced this.
What's progress like in middle and lower income countries? I've heard from one colleague in Melbourne that there are pre-operative assessment and perioperative medicine programs in Mongolia. Do you know how things are going generally for pre-operative optimization?
I know what it's like in most European countries because we host their multidisciplinary teams learning from our hospital on perioperative care in colorectal cancer, and they have different resources. They might even have less social factors that influence outcome. They're less obese in some countries because they just lack of anything. And on the other hand, they might have 80% smokers. There's a lot of variation in that.
I was at the World Congress in Singapore earlier in the year where there's a lot more representation from lower income countries, and we had a session on prehab. And there is interest, but again, very different challenges in a lot of lower income countries. A greater proportion of surgery is emergency and access is very limited. The idea of people being able to come back and forth to institutions apart from the day of surgery seemed to be very challenging. But there was a lot of interest. We're not sure that there is such a thing as a universal prehab, but in terms of the basic advice for diet, nutrition, exercise, and the importance of smoking cessation seemed to be important. But I think they're a long way from being able to implement the supervised programs that you may have been hearing about in the last 2 days.
Besides, they have a lack of staff.
I'm going to change tack a little bit and look at the balance. In order to justify this, there are the cultural changes in the evidence base. So we get the evidence base first, and I suspect I might hear different answers from the two of you, but do we need more trials?
We will always need more trials, but I think the time for randomized trials is over. There's so much evidence now, so many small studies that have demonstrated it. It's a hard time setting up a randomized trial. All trials have about 25% of inclusion, and so there are also selected patients that will have their biases anyway. At least in our country, we can't anymore because patients do want a program before surgery.
I still think there are some challenges with the literature. I think in colorectal cancer, there's a huge amount of data now, but other specialties, there's still not a huge amount of data. In some countries, we are not as far forward as you are in Holland with the implementation. To convince funders that it is relevant to other patient groups, I still think there is an opportunity to do trials, but I think we'd be looking more at complex trial designs, platform trials. There are definitely locations where there is nothing implemented yet in terms of individualized care, so you could do a step. There are ways around the problems of control and non-control by having centres switch from not having a program to having a program, for example. I do think there's opportunity for that.
But
I think
do you then think you need proof for any kind of surgery, or could you just say if it works for pancreatic surgery, colorectal surgery, bladder surgery, then it will probably work for all the other areas?
So major abdominal, I would agree. I think people have issues about other things such as adjuvant cancer treatments and therapies, non-surgical cancer therapies. And I also think non-abdominal surgery, there is more doubt amongst people working with vascular patients, for example. And I totally agree. We do not need to do every single type of patient, a study for every single type of patient. We'd be here forever, and that would be a waste of resource. But with those platform trials, I also think we should be looking at trying to design something that would be implementable at the end by having the trial and starting. You end up with a workforce that would be potentially able to continue afterwards, because the workforce is a major issue, certainly in the UK, and from my conversations, I think it still is in other places. The models of care are still not clear. I think one of the big challenges, again, we've talked about it, is the role of digital interventions and support. There is a danger of complete reliance on non-face-to-face interactions, and I think there is suggestion from the literature that may exclude certain groups of patients, and actually in some cases the very ones. So I think one of the problems is if you just let people implement at the moment, they're going to try and implement in some institutions where you have the funding problem most around the world at the moment, and giving people an app seems to be an easy answer. I think that is not without potential problems. We need to evaluate some of those technologies before we accept.
Kate is in anaesthesia, one of our preeminent trialists globally, so led several very big trials. And you're new to the prehab field. So we have maybe 3 trials with more than 100 patients randomized.
Okay.
Correct me if I'm wrong. A couple of multi-center trials, only one of which is so far reported. How many patients in your study?
250 at both arms, 125 about.
If it wasn't prehab, it was another intervention. Do we need more trials or do we not need more trials?
We definitely need more trials. The main problem is these trials being done in centres of excellence in the presence of charismatic enthusiasts, and they're limited in their generalisability. In particular, with respect to, I suspect there may be a problem with financial or resource diversity. I haven't seen anything at this meeting about the average income or education of the people who engage well in prehab programs, but I assume that people with more personal resources are advantaged in those systems. We'd need to see how it works. There was a great talk where someone mentioned that patients who don't speak the local language are not often included in these trials. In Melbourne, 30% of our population comes from countries where English is not spoken. We have 40 different languages spoken at our hospital just a couple of kilometres away. So I can see the need for some global multi-centre work, but I think the innovative designs are the way to go, Denny. The problem with the step wedge design is that it has an innate assumption that the intervention's there to stay, and it may be hard to shoehorn it out of the organisation if it's proven not to be useful. What do you think?
I think you're right. But I think it overcomes some of the barriers that Gerrit's alluded to, which I think are very real. It seems that the enthusiasm has advanced beyond the literature to some extent. So trying to convince people that this doesn't work would be challenging. I completely agree with you with the challenges for access. There's some interesting work going on in the UK at the moment, looking at all the prehab literature and trying to distinguish in terms of access from low economic social groups, people who have other hard to reach characteristics, so English or whatever, than that local language not being their first language. And I do think that that's something we really need to pay attention to as we develop these services. If we're not reaching those patients because they can't afford to travel, won't travel to the gym, don't interact because culturally it's difficult to engage in exercise and groups, we need to make sure we're not excluding people unintentionally.
Your trials of a couple of hundred people probably cost the same as our trials of a couple of thousand people, because our interventions are implemented for free by anaesthetists who are paid by health services generally, and we don't need armies of ERAS nurses and physiotherapists and other people to implement the intervention and to do the follow-up. Your studies are much more expensive, and that makes it highly challenging to do the trials that you would probably be dreaming about doing. Establishing a platform trial in the UK would cost £10 million, presumably.
Yes, in the region probably. We haven't managed to get over the line of achieving that.
Actually, when we did our study, we tried to focus on getting our proof first that prehabilitation works to reduce complications. We're sitting here, we're all believers, we hear presentations about reduction of complication, and we thought, well, we better first do a large randomized trial, but we were thrown back by COVID. We first wanted to prove with the highest possibility of finding this proof with high intensity, multi-modal prehabilitation, which was supervised by physical therapists, by true professionals, to get the evidence. I think we don't need these trials anymore.
It's analogous to a phase 3 trial, and what you need now is your phase 4 trials.
I think the policymakers would say that's great. You've shown us that it can work in the hands of enthusiasts in a particular specialist context. But if we throw it at a whole health system, will it work and will it have the same benefits? Which is the argument for some kind of large-scale evaluation, trial or otherwise.
We need real-life data instead of randomized trials. That's the next step.
And what about changing. We're only doing these trials because of ill health in society. And which we're essentially trying to. Some of the interventions are effectively implementing WHO guidelines at a straightforward level for all people under all circumstances. Is there anything we can do to either change or help society change our world? If you see what I mean.
We all want to change the world, but I'm just a humble surgeon. I have these patients 4 weeks prior to surgery, and I try to make the best out of it. The best I can reach is that all patients that enter my hospital will have attention for mental, physical, and metabolical fitness. That's the ultimate I can reach. I cannot change the world, but I wish we would all sit on the couch less, not watch Netflix, eat better food, healthier food, and so on. But I cannot change the world.
But I think you've done some advocacy work involving patients to see if you could get them to drive the change.
They should drive the change.
I think we can have a role and should have a role in promoting the public health side of this, as I spoke about in my talk yesterday. At the moment in the UK, there seems to be a window of opportunity. We've just changed government. They're very receptive to the idea of prevention. They're very receptive to the digital agenda. And one of the great things about prehab is that it's really easy to communicate to non-medics. And most people get it and almost can't believe that it's something we're not doing already. A bit like our consumer yesterday spoke to us about, they're just disappointed that they haven't got access to this. I remember being interviewed on Radio 4 in England, which is a great pinnacle of my career because I like Radio 4, the Today programme about our new surgery school. The presenter said to me, "You've done something really new and innovative, and what are you doing exactly?" And I said, "We're telling people to eat well, give up smoking." And he actually laughed and do some exercise. He said, "This can't be thought of as being innovative. Surely everybody does this. And that's normal before surgery." This is one of the problems. Everyone knows about this stuff, but nobody's doing it. If we don't make a point of trying to lobby healthcare and others, then I think we're just stuck in the status quo. One of the problems about the prevention agenda is the belief and hope that you will reduce the demand for secondary care, but there's going to be a delay. So until you've reduced that demand, you're going to have to run both systems. So it will involve a lot of investment early on, but it's persuading people to do that. If we could get people fitter in primary care, it would reduce our workload. Equally, in the UK at the moment, our primary care system is overwhelmed. If you just say it's their job right now, it won't happen.
Maybe we are already doing good things. We're not only educating one patient, we're educating their whole family. Yeah. They'll spread the word for us. Just by running programs like this and focusing on a healthy life, we will reach further than we think.
It's a teachable moment. You get a patient at a vulnerable point and impress them with the necessity not only to do this before their cancer surgery, but also to change their life for the better.
I don't know the stats in Australia or the Netherlands, but in the UK, on average, each individual has at least 5 surgeries in their lifetime. In America, it's nearly 10 now. So that's a number of separate touch points where you can give health messaging when they're likely to be particularly receptive to it because an individual will be particularly focused on their health. And I'm not sure that almost feels to me like a bigger impact of prehab if every time we spoke to a patient we emphasise this than some of the more formal programs.
Can I ask you a controversial question? In Australia and America and around the world, there's increasing use of GLP-1 receptor agonists for diabetes and also for weight loss. Do you see a role for those agents in extended prehab programs or mainly to help with weight loss?
I'm a non-believer. I'm afraid that people are just going to take a pill to compensate for their ill-healthy lifestyle. That's the same with bariatrics. You can offer a patient a bariatric procedure if they are out of control. But actually all you do is try to give them a situation in which they can regain a normal lifestyle. And if they don't, they don't. I think there's potentially a worldwide epidemic when we start supplying pills for weight loss.
What do you think, Denny?
I think there are lots of challenges. More and more people are going to be on these drugs anyway, and certainly in terms of cardiovascular profile, we're involved in a program grant looking at prehab for cardiac surgery, and one of the investigators was saying by the time we finish this trial, it'll be a non-issue, and in that group of patients, mostly it's weight loss rather than the high risk of malnutrition that we see in major abdominal surgery. So that's very common at presentation, but obesity is a bigger issue amongst the cardiac surgical group, and they are increasingly being prescribed not just for diabetes, but also for heart, in cardiac disease. So I think they will become more common, but there is the issue that they are expensive, and there is the issue that people can't take them endlessly, and when people stop, they tend to put the weight back on. I don't think it's a need to teach people about healthy eating. In the context of cancer surgery, you're not really wanting people to lose large amounts of weight. The aim of nutritional support is to improve nutrition because you may be obese and sarcopenic and malnourished, to enable them, A, to respond to exercise training, and B, the challenge of surgery and the immunological challenge therein. So a weight loss pill will not address that side of the malnutrition challenge. But I think it's something we're going to come across more and more.
Now, I think we're running up against time, so I'm going to ask the two of you each to share with us one gem from the week. Look, what your take home will be from coming to Melbourne that you'll remember and think, I hadn't heard that before, I really want to remember it.
The thing is that every time we meet, I get this feeling of mainstream positivity and people thinking like one mind. And that's what I love about a conference like this. And this one has been exceptional this far.
I think my biggest take home from the conference so far is just how far we've come since 2019. I remember in 2019, that lovely conference in the London Museum. I was lucky enough to be there, but we didn't have a single multi-centre trial with an outcome that was a clinical outcome at that point. And we didn't have any implementation at large scale of prehab that we could report on. We were excited about these trials coming out. And when we've moved forward, we've got your study listening over the last couple of days. There are now large numbers of programs internationally that have been adopted with really exciting results that we're seeing. I know some people in the audience are frustrated because in their own centre they haven't got access to any of this yet. The rate of change of practice is really reassuring, and the consistency of the signal, actually, because I was a little bit nervous at the beginning that it may just be the zealots. I think we probably are in that group. But more and more centres in lots of different circumstances with lots of different groups of patients are finding much the same thing. And I find that really assuring. And the other new thing I've learned about is a magic, which is apparently unique to Melbourne, a very good cup of coffee that I learned about on the walking tour of the culinary delights of Melbourne.
So it's a flat white that's a bit stronger and a bit shorter.
A bit less volume.
In all other respects, it's exactly the same as a flat white.
Great.
Yes.
I'm not expert, but it was good.
So well done. We nearly managed to finish on two very positive messages, but now we've got distracted by coffee. Okay, thank you so much to both of you. Thank you very much to the audience. You can listen to Top Med Talk on all your favourite social media platforms and on YouTube. We'll look forward to the rest of the conference. And Gerrit, are you going to tell us where that meeting is?
Sometime.
Okay. Thank you very much.
Obviously
Thanks,
not.
everyone.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.